I'm going to follow on from Kathy's talk about spines and resilience, if you like. Any guesses who this chap is? Not Father Christmas. I'm not particularly religious, but if you want to get resilience, get religion. So this is a study that they took religious and non-religious people, and they electrocuted them. They gave them an electrical signal to their hand, and they asked them how painful it was. Then they took the religious group and showed them a religious icon and a non-religious icon. And if they were viewing a religious icon or what they had a belief in, so different religions, they hurt less. Okay? So if you have a belief, you're going to be more resilient. And of course, what picture I showed you, of course, is, I won't go through, that was Karl Marx, wasn't it? And he said, opium is the religion of the people. Well, he was true. 100 years ago, neurobiology, but actually, we can all get resilience different ways. So this is a question I'm often asked as a spine doc. Will I get better after a surgery? Okay, and I'm going to go through some of the factors of that. But what's this got to do with what the Rolling Stones and the Wizard of Oz? What's that got to do with spine surgery? Now, that's what we understand about pain mechanisms. Don't try and take that down. That's probably better, isn't it? That's 300 years old. That's Cartesian logic. And of course, being French, he said, fire, input, rings a series of tubules, you draw away. That's pain. We know now that it's modulatable at all levels: transduction, transmission, and perception. And whether it's your anti-inflammatory super, your non-steroidals, or whether it's your confidence in the perception, people will react differently. They'll rehab differently. And some of that's in our hands. And most people, if you're going to have a discectomy surgery, you'll do very well. 80–90% of people will do very well. We know that's true. There's a small tail that won't. Okay. The nice thing about this, and this is a sports trial, of course, is at 5 years and at 10 years, your outcome's the same, whether you have surgery or not for radicular pain. That's quite good prognostically. Surgery, you'll get better quicker. We know that. You'll be back on the running track quicker, so it has its place. But people shouldn't be fearful that if they don't have surgery, they're not going to do as well. First 2 years, yes. 5–10 years, no. Okay. And that's a spinal pathway, isn't it? Effectively, when the patient walks through the door, you're this, isn't it? What you want is Dorothy. Because Dorothy's a coper. Whatever you do, she's going to be back out on the running track, she's going to do well. How you treat Dorothy is going to be quite different from how you treat the fear-avoidant lion there, because he needs difference. We don't put them through the same rehab program. We don't expect the same outcomes. They shouldn't expect the same outcomes. We're going to have to handle them differently. And what we really need to do is look at the Dorothys and the lions when they're approaching surgery, and I'll explain why. Half of us will have some back pain in this year. Less than 10% will go to a surgeon, go to your GP, 1 in 10. And less than 40% of that will actually be bothered. You can't put on your hosiery. And 40% will be extremely bothered. You can't go to work. And that's probably the people that wash up at your door first. That's still 100,000 people in London. And of those 100,000, you are 4 times more likely to have anxiety and depression if you have back pain. So if they fail the pathway, and gladly it's not many, go down that pathway to be presented to a surgeon, they're much more likely to have psychopathology. And how do we deal with that? And in this paper, less than 20% of people having spinal surgery will actually think we've exceeded their expectations. 40% we won't come up to their expectations. So it's important to understand what the patient's goals are and what we're going through to make them right. And when we looked at that, clinical impressions of patients before surgery, they are surgeons and non-surgeons, physicians, who could pick out who's going to do well. And the surgeons didn't do badly. 20% got it right, comparatively. 40% of the non-operative surgeons were better at assessing patients' outcomes. Not from a surgical point of view, not from a bit of metalwork point of view, but actually their long-term outcomes. And it will come as no surprise to you guys that if you smoke, if you abuse substances, if you've been off work, if you're not enjoying work, these are going to have different outcomes. And we should assess these people in different ways. If you've got a high pain sensitivity, fibromyalgia, polysymptomatic, if you're depressed, if you're anxiety, we should look at these. And you should construct these red, yellow, green, amber, green. That's not to say you don't need surgery, because sometimes you will need surgery, but to expect to follow the same pathway is different. We should look at these in a different way. What do you think is the biggest predictor of outcome in any spinal surgery? One question. Do you think you'll be back at work? 20 times odds ratio of predicting where you're going to be at 3 to 6 months. If your patient says to you, I don't think I'm going to be back at work, I'm not keen to go back to work, they're going to be right. Okay? But that's all psychology. That's not whether you fuse one level, put a disc replacement in. It's all the psychology behind that. Now, in all surgery, depression is thought to have a bad outcome, but that's not true, as you may have heard. And what happens is that those people who are anxious and depressed because they've got pain, and it's a short-term reactive, and when you take that pain away, they get better. And there are those people that are anxious and depressed who then had back pain, and that doesn't get better. And we need to handle those in a different way. And when actually we looked at that, or when actually the Cambridge neurosurgeons looked at that, looked at 100 cases, they showed actually whether you had psychopathology, anxiety and depression, you reacted on the same trajectory. You improved the same, but you were polysymptomatic before, you remain polysymptomatic. And sometimes, I'm sure you've seen this, people anchor. If only my surgery had gone better, if only my rehabilitation got better, this wouldn't have happened to me, these life events wouldn't happen to me. If they forget how they were before, they pin a lot of hopes on that. And it's important to make those changes and say, look, actually, we're going to get you better, your leg pain's going to be better, but you're going to be the same person. And of course, that's the Rolling Stones, isn't it? Yeah. So you don't get what you want, but you get what you need. You'll get back. And there are some changes you can do, quite profound changes. If you have 300 milligrams of pregabalin twice a day for 48 hours around your spinal surgery, you'll have less pain and greater function at 3 months. Now, the effect tends to have changed at a year. You've gone back to the norm, but in your early rehab, you'll be better. So if you get these people, treating them differently, there are things you can do, there's cognitive behavioural therapy, but looking at different pathways for them are important. But your expectations of what you're telling the patient when they're going for any intervention, be it spinal surgery, has got to be different. There are things that we can do. The good physician treats person, but the great physician treats the patient with the disease, and that's of course what you guys do. Thank you.